Hi, my name's Leon Ryback, and I'm a musculoskeletal radiologist at NYU Langone Medical Center. In the next 30 minutes or so, I'll be talking to you about imaging of the spine. The way we'll break this talk down is we'll talk about the imaging modalities and a little bit of anatomy, and then we'll go imaging by disease process, touching on trauma, tumor, infection, arthritis, and finally finishing up with something on postoperative imaging. So beginning with the available modalities, plain radiography remains first-line imaging, giving good visualization of both osseous anatomy and alignment, and we can make some inferences about soft tissue, including disc pathology as well. The standard protocol involves AP, lateral views, and a cone-down lateral view. The EOS machine has upped the ante, giving us beautiful discrimination of both bones and soft tissues at a radiation cost saving. We can proceed to CT scanning for triplanar visualization of the osseous anatomy and improved soft tissue delineation. However, it's not quite as good as MRI. Here you can see a nice disc delineated both in the sagittal and axial images. However, it more commonly looks like this, where it's difficult to distinguish the back of the disc from the adjoining thecal sac, and it's harder to distinguish the contribution that disc pathology makes to the degree of canal stone. We can better delineate the thecal sac and nerve roots by injecting iodinated contrast material during myelography, which we may do if MRI is contraindicated or in the post-operative setting. You can see on the axial images the nerve roots nicely outlined by the dye. MRI has quickly become the gold standard for spine imaging. In the lumbar spine, we will typically do sagittal and axial T1 weighted images. On T1 weighted images, fat is high in signal intensity both within the vertebra as well as outlining the exiting nerve roots in the neural foramina. It also very nicely delineates the ligamentum flavum, sitting ventral to the articular facets, as well as the facet joints themselves. We also do sagittal and axial T2 weighted images where fluid is bright in signal intensity, giving us a myelographic effect and delineating very nicely the thecal sac and nerve roots. In the cervical spine, we replace the axial T1 weighted image with a gradient echo image. That's because T1 is not as of much value to us in delineating the exiting nerve roots in the cervical spine, and this is a second myelographic sequence, if you will, which gives us a better chance of seeing what's going on with the cord and the exiting nerve roots. There are some special sequences we can use. If we really want to accent edema in areas where we're trying to accent it, we can use something called fat saturation. Here, a plain radiograph that was read as normal. When you do the fat saturated sequence on the right, you can see the bright linear signal intensity going through the vertebral body, which represented an acute compression fracture in this patient who'd fallen off a horse. Coronal imaging is not part of our routine protocol. However, we will utilize it when imaging patients with severe scoliotic curvature. Let's move on now to the first of the pathologic groups and talk about trauma. When it comes to cervical spine trauma, we know that the emergency room physicians use the nexus criteria. If those criteria are met, they're on the left, you don't need any imaging of the cervical spine. If the criteria are not met, it depends on whether the patient has a neurologic deficit. If there is no deficit, you can proceed directly to CT of the cervical spine. If there is a neurologic deficit, you may want to get X-rays of the thoracic and lumbar spine, a CT of the cervical spine, and then proceed to MRI to evaluate the status of the cord. So the standard of care in the emergency room setting of trauma is a screening CT of the cervical spine. If there is neurologic deficit, if it's an unstable injury or the patient has been obtunded greater than 48 hours, you may want to proceed to an MRI. A word about Flex X films. This is not recommended in the acute setting. It can lead to adverse outcomes for the patient and does not commonly add a lot of information to the workup. Let's take a look at some craniocervical injuries. First, let's do a little bit of anatomy here. In the cervical spine, other than the osseous elements, we know that we have certain reinforcing soft tissue structures: the anterior longitudinal ligament, the posterior longitudinal ligament, the ligamentum flavum anterior to the lamina and in front of the facet joints, the facet joint capsules themselves, and then the interspinous ligaments between the spinous processes. In terms of bony anatomy, with a quick survey, we're going to look for integrity of the bony margins of the central canal and of the vertebral foramina. We're going to analyze the facet joints, and they should look like a hamburger with the flat surfaces opposed. We can look at certain key lines when assessing alignment: the anterior spinal line, the posterior spinal line, and the spinal laminal line. On the sagittal images, we want to look for alignment of our facet joints and to see if there's normal alignment at the atlanto-occipital articulation, as well as any widening of the facet joints. On coronal images, again, we can take a look at the facet joints and make sure they're normally aligned. Look at the atlanto-occipital articulations, and then paying special attention to the C1-2 articulation, we look to see that the lateral margins of C1 and C2 line up, and that the space on either side of the dens is equal when there's no significant rotation of the head. Let's move on to some injuries and deal first with hyperflexion injuries of the cervical spine. A hyperflexion injury, some of the findings that we are looking for is interspinous widening or malalignment of the facet joints, widening of the posterior margin of the disc space, and an anterior step off, which may be associated with kyphosis. And you can get nicely depicted here in an actual case. There is a spectrum of injuries depending on the severity of the injury, all the way from hyperflexion sprain on the left to bilateral facet dislocation on the right. This is a case of hyperflexion sprain. We have widening of the interspinous distance, malalignment and widening of the facet joints, focal kyphosis anteriorly. On the subsequent MRI, you can see disruption of the interspinous ligaments, widening of the interspinous space, and fluid and edema both within the facet joint capsule and in the surrounding soft tissue. Here another case on CT. In this instance, we have bilateral facet dislocation with perching of the facets upon one another. You can see the anterior step off and focal kyphosis, widening of the interspinous space, and actual fracture of one of the articular facets. We can proceed to a full dislocation where we have now jumped facets, and you can see the degree of anterior step off has also increased in this patient with these bilateral locked facets. On axial images, you have what's known as the reverse hamburger sign, because you can now see the convex margins of the opposing articular facets aligning with one another. The radiographic finding of a flexion injury, which portends poorly for the patient, is the presence of a flexion teardrop fracture. Here you can see a case with a flexion teardrop fracture. Note that the facets are widened and slightly malaligned, but the posterior margin of the affected vertebral body is retropulsed into the canal. These can be fairly severe injuries. I'll show you one here where you have a kyphosis and posterior displacement of the proximal cervical spine, resulting in severe cord injury. And these patients commonly present with the symptoms of the anterior cord syndrome. Let's move on now to hyperextension injuries. We look for these injuries where we have evidence of a blow to the front of the head or the face. And we want to keep in mind that even though the blow comes anteriorly, that you can have posterior translation at the time of injury, but there can be recoil mechanism. And by the time we image these patients, they may look like they are fairly normally aligned. And an example here where we have widening of the anterior disc space, and there's a lot of large osteophytes ventrally, but there's question of some bony debris at this particular level. If we go to the CT scan, you can see that acute fracture fragment and a little bit of associated widening of that disc space. And this is what the patient looked like at MRI. You can clearly see disruption of the ventral margin of the disc space and acute disc herniation resulting in cord compression with edema in the posterior paraspinal soft tissues. Let's move on now to the thoracolumbar spine. 40% of thoracolumbar spine fractures occur at the thoracolumbar junction. Why is that? Because there's a change there from the rigid thoracic spine to the more mobile lumbar spine. There's a change in alignment at that level as well, and there is a change in orientation of the facet joints from the more coronally oriented thoracic facet joints to more sagittally oriented lumbar facet joints. There is a three-column theory of injury in the thoracolumbar spine. The anterior column includes the anterior margin of the vertebral bodies and disc spaces. The middle column includes the posterior longitudinal ligament and the very posterior margin of the vertebral bodies and discs. And the posterior column is everything posterior to this level, which includes the posterior arch. In terms of stability, if you have two of the three columns injured, that's considered an unstable injury, which makes the middle column the. With respect to plain radiography, we can see some indirect signs with paraspinal widening, indistinction of the mediastinal contours in the presence of hemothorax. However, these findings can be very difficult to distinguish on these portable x-rays in the ED setting. Here an example where you would be hard-pressed to find the thoracic spine injury, and when the patient went to CT, you can see this severe fracture dislocation in the thoracic spine. For these reasons, MRI has a large role to play in diagnosis of thoracolumbar injuries, giving us better delineation of the soft tissues and ligaments, very sensitive for detecting multiple non-contiguous fractures. However, we know that there's limited availability of this resource at many medical centers. Let's look at some actual injury patterns. Compression fracture, by definition, involves the anterior column and is a result of forced flexion, resulting in a wedge shape of the vertebral body. In most cases, seen at two levels here, this is a stable injury. If we move on now and involve both the anterior and middle columns with more of an axial load, this can result in a burst fracture, which can have both stable and unstable configurations. Here a case where you have significant retropulsion of the posterior vertebral margin into the canal, which can result in neurologic injury. That's an unstable injury. Here on plain radiography, we can see at L2 that there's loss of height. There's widening of the interpedicular distance. And this is an unstable burst type fracture configuration on plain radiography, better delineated in the lateral projection, where we can see retropulsion of the posterior superior margin, and further delineated on CT. The last fracture we'll talk about in the thoracolumbar spine is the chance type fracture. This always involves the posterior and middle columns and may involve the anterior column. This is due to flexion and distraction. It's also known as the seatbelt injury, which I'll show you in a second. Here is an example on plain radiography of a chance fracture with obliquely oriented linear lucency extending through the middle and posterior columns. This is an unstable fracture. This is an illustration of why we call it a seatbelt injury. You can see the seatbelt here tethering the patient at their waist, and you have forward flexion of the torso with compression ventrally and distraction energies posteriorly. This can result in disruption of the soft tissues, i.e. the disc and posterior ligamentous structures, or it can result in fracture through the vertebral body and into the posterior elements. On plane radiography, we can look for a horizontal split of the vertebra and the pedicles, increased interspinous distance, widening of the rib spacing. On CT, we can better delineate the fracture with widening of the interspinous distance and fracture propagating from the vertebral body into the posterior elements. Before we leave the topic of trauma, I want to touch quickly on pars fractures or pars defects, which is felt to be a stress injury, perhaps due to repetitive trauma, particularly in young athletic patients. We can see it on plane radiography as disruption of the neck of the classic Scotty dog on oblique radiographs. We can also pick it up with nuclear medicine imaging, where you'll see a hot spot in the affected posterior elements. And it's very well delineated on CT, where we can very clearly see the disruption of the pars. The point here is they can be very difficult to pick up on MRI, and this particular pars defect was missed on MRI, only picked up later at subsequent imaging. Let's move on now to the category of tumor. Within the spine, we can break it down into malignant and benign. In the malignant category, Mets, myeloma, and lymphoma being more common, and chordoma being an uncommon malignant tumor. In the benign category, the vast majority of lesions being hemangiomas, but there are other things like Paget's, egran, osteosteoma, osteoblastoma, and aneurysmal bone cysts that can be. When faced with multiple lesions in the spine, as in this case where there's obvious replacement of a central vertebra there by sclerotic met, but also associated mets along the margins of that site, then we think first and foremost of metastasis, and this is a case of metastatic prostate cancer. Here, a solitary lytic lesion with preservation of some internal trabecula. Whenever I see something like this, I think about plasmacytoma, and this appearance on axial CT images has been likened to the brain. Here you see that patient with significant compression of the vertebral body and retropulsion of soft tissue mass into the canal. Here, a permeative lesion on the right side of the sacrum with obscuration of the surrounding fat planes, including the fat within the adjoining neuroforamen. We see why when we go to the MRI, because there's a lesion in the bone that has spilled out into the surrounding soft tissues and into the canal, and this is characteristic of lymphoma. Here, a midline lesion. The patient is prone in this picture. You can see that there's a soft tissue mass in the presacral space associated with areas of calcification. This is better delineated on the MRI that shows it to be somewhat lobular and T2 bright. And this is a chordoma, which can be found in the midline, both in the sacrococcygeal region as well as at the skull base at the level of the clivus. Here, a typical benign lesion. You can see at L3, you have a striated appearance to the vertebral body. When we go to the MRI, you can see that that particular vertebral body is brighter than the surrounding vertebral bodies on both T1 and T2 weighted images. That's due to the presence of a large amount of fat, and this is characteristic of the benign hemangioma. Here, another example of hemangioma, where on the axial image on the right, we can see the characteristic polka dot formation with the maintained vertical trabecula traversing the vertebral body. Here, another disease entity where we have mild expansile deformity of the L5 vertebral body. Difficult to see on plane radiographs because of the overlying ilium, but when we look at the CT, we can see it has a somewhat picture frame appearance and a mosaic pattern on the axial images on the right, and this, of course, is the classic appearance of Paget's disease in a vertebral body. When we have what's known as a ivory vertebral body, a dense blastic appearance of the vertebral body, The differential there can be metastasis, as we saw earlier with our prostate patient, lymphoma, or Paget's disease. In this case, this was Paget's. The finding of flattening of a vertebral body or vertebra plana in a younger patient may evoke the diagnosis of eosinophilic granuloma if there are multiple levels of compression associated with osteopenia. One might consider leukemia. Here, another characteristic appearance of a benign lesion along the posterior lateral margin of the vertebral body with central sclerosis and surrounding lucency and reactive marrow edema on the corresponding MR image. And this, of course, is characteristic of an osteoid osteoma in a young patient. This is the older cousin of the osteoid osteoma, if you will, an osteoblastoma, which can be larger and can result in compression in soft tissue structures. Another characteristic imaging appearance on MRI in this lesion with multiple fluid levels evoking sedimentation of contents of blood-filled cysts in this aneurysmal bone cyst. The one soft tissue lesion I want to touch on quickly is this disease entity, which can grow in the region of the neural foramen, taking on a dumbbell-shaped configuration due to the bony constraints of the foramen. And this, of course, is a neurogenic tumor, either a neurofibroma or schwannoma. Let's move on now to infection. It's important to note that the radiographic findings of infection in the spine may be somewhat delayed and lagging behind the disease process by 10 to 14 days. We're looking for loss of bone definition with erosion of the end plates, lucency within the vertebral body, loss of height of the disc space, bony destruction, progressive kyphosis or scoliosis, and in the healing phase, increased sclerosis. Here's a case of a 37-year-old with back pain and elevated inflammatory markers. Not much on the plain radiograph and MRI when we look mid-sagittal. Far lateral parasagittal, we see a little bit of edema in the soft tissues. This was read as normal. Patient came back subsequently and now has early changes of osteomyelitis in the vertebral body with increasing findings in the paraspinal soft tissues, and this was felt to be osteomyelitis, which was biopsy proven. Here another case where we can see the plain radiographic findings of loss of disc height at 2 consecutive levels here. However, when we look closely, there's a question of erosions or lucencies overlying the L3 and L4 vertebral bodies. When we go to the MRI, it becomes apparent that there is in fact discitis and osteomyelitis at L3-4, and that the changes at L4-5 just reflect discogenic degenerative changes. So MRI was very helpful here in delineating the site of infection. When it comes to findings of MRI, we look for T1 hypointensity of the disc and destruction of the end plates, corresponding T2 hyperintensity of the disc, paraspinous or epidural inflammatory changes, and contrast enhancement on post-contrast imaging. When should we proceed to biopsy? Well, if surgery is clearly indicated, you should biopsy in the OR at the time of surgery. If blood cultures are positive, we should be treating based on those results. If blood cultures are negative, make sure that the patient is off antibiotics for an appropriate period of time and proceed to the biopsy. If the biopsy results are positive, you can treat based on that result. If the results are negative, you can treat empirically, or you can opt for a second biopsy. A caveat here, if there's fluid within the disc space on MR imaging, make sure to check your corresponding plain radiographs and CT. If you find vacuum phenomenon, most likely that is not an infected disc space. It's very unlikely that you have air in the disc space in the setting of discitis. Other confounding variables, here is a patient with profound destruction of the disc space, sclerosis, debris, some degree of malalignment, and this was a patient with neuropathic arthropathy. Here, a patient with dense vascular calcification in the aorta, and multiple areas of erosion involving the end plates. However, this was not infection. This is known as the discopathy of dialysis in patients with chronic renal failure and can be due in part to deposition of amyloid. And a final case here in this patient where it appears that we have significant erosions involving a disc space in the thoracolumbar spine, maybe a second level further up. And this is a patient with the inflammatory lesions that can be found in the disc spaces secondary to ankylosing spondylitis. Let's move on now to arthritic conditions, including disc disease. Let's talk first about abnormalities of disc contour. At the lower end of the spectrum, we have a disc bulge, where there is concentric bulging of disc material beyond the confines of the disc space, involving greater than 50% of the circumference. It's important to remember that many of these can be asymptomatic. Here we have a case. We take a look at the end plate of the inferior vertebral body, and when we go to the disc level, we can see that disc material is bulging concentrically beyond the borders of the vertebral body. When we move into the realm of true disc herniations, on one end of the spectrum we have a disc protrusion, where the material sticking out of the disc is wider at the base than it is at the apex. The implication being that some of the outer annular fibers are intact, and again, these may be asymptomatic. Here are two examples of small central and slightly left parasagittal disc protrusions. A major category of disc herniation is a disc extrusion, where the herniated disc material is constricted at the neck where it escapes from the annulus and is wider at the apex than at the base. These can migrate in continuity with the parent disc. There may be an associated inflammatory reaction, in part due to the release of nucleus pulposus, which can mediate an inflammatory and nociceptive response. Here, a nice example of a disc extrusion. If you look at the sagittal image, you can see that it's constricted where it's escaping from the parent disc. You can also have sequestered disc fragments with no attachment to the parent disc. You may be lucky enough to see a low signal line between the parent disc and the fragment. If you're also fortunate enough to have contrast on board, you can see that sequestered fragment completely surrounded by inflammatory reaction. It's important to remember that these can pull off little shards of bone that can then penetrate the dural sac. With respect to disc herniations, we can describe the position in the axial plane as central, lateral, foraminal, or far lateral extraforaminal. Example here of a central phenomenon, a left lateral in the lateral recess, a foraminal disc herniation, high intensity and signal on the left here, and a far lateral extraforaminal disc osteophyte. One mimic of disc herniation or sequestered disc is seen in this case, with signal intensity material posterior to the L5S1 segment, somewhat hyperintense and lenticular in shape. This was felt most likely to reflect an epidural hematoma, and over time was seen to resolve and shrink in size. One mention about thoracic disc herniations: they tend to be large, central, and can mineralize or calcify in a large proportion of cases. A few words about the facet joints. They are synovial joints and can undergo degeneration like any other synovial joint, with cartilage wear and early subcondylar cystic change in the case on the left. In the case on the right, we have more severe arthrosis with marked bony hypertrophy and what we call mushrooming. When you have degeneration of the facet joints, you can get formation of these large synovial cysts, which can be in continuity with the facet joints and can have mass effect on the thecal sac and neural structures. You can see here we're doing a direct puncture of this particular facet cyst. Another way of handling it percutaneously would be to access the facet joint and pressurize the cyst indirectly by blowing out the facet joint. In the cervical spine, we also have to worry about the uncovertebral joints, which, along with the facet joints, can result in severe neuroforaminal narrowing, even more profound in this case on the left. Degeneration of both the disc and the posterior elements can result in degenerative listhesis or instability. We can do flex X films and look for translation greater than 3 millimeters or rotation and change of the slip angle greater than 9 degrees. An associated sign that we can see on MRI is the presence of large facet joint effusions. Let's leave degenerative arthritis now and touch on several other arthritic conditions. In this case, I'm going to draw your attention to the atlantoaxial articulation, where we have large soft tissue crowning the dens. This, of course, is pannus material in a patient with rheumatoid arthritis who subsequently developed atlantoaxial instability. And here you can see posterior translation of the dens and impingement on the cord in the region of the foramen magnum. We want to be very careful with these patients, and this is why patients going for surgery for other reasons with known rheumatoid may get flexion and extension films. Here, a patient with ankylosing spondylitis with flowing ossification along the ventral margin of multiple contiguous vertebral bodies, as well as fusion of multiple facet joints. This can predispose the patient to pathologic fracture with relatively minor trauma, as can be seen in this case here. The same can be said of diffuse idiopathic skeletal hyperostosis, or DISH, where bulkier anterior ossification also fuses the adjoining vertebra. Since we're touching on DISH, I want to talk about another interesting disease entity you should be familiar with that is associated with DISH, and that is ossification of the posterior longitudinal ligament. This can be space occupying within the canal and was the reason that the Japanese came up with laminoplasty as a surgical procedure. One other interesting disease entity is juvenile thoracic kyphosis, or Scheuermann's disease, where we see anterior wedging greater than 5 degrees of at least 3 adjacent vertebral bodies, resulting in kyphosis. In the last few minutes, I'd like to go over post-surgical imaging. When we talk about complications of spine surgery, we can group it according to temporal relationship to the index surgery. In the immediate postoperative period, where you may have wrong level surgery, inadequate surgery, or hardware graft malposition. In the short-term period, where you can have temporary relief of symptoms with recurrence of pain or other symptoms due to infection or dural tear with CSF leak. In the midterm period, where we can see recurrent disc herniation, scar tissue formation, or arachnoiditis. In the long-term period, months to years, where we see the mechanical effects of adjacent segment degeneration, instability, or pseudoarthrosis, and then the anytime complications. Let's begin in the immediate postoperative period. And we have this patient where a screw is placed inadvertently into the canal, and that patient may need to go immediately back to the OR to have that removed. Here, where there was a T-lift done on the right side, and the graft slipped back into the region of the neuroforamen, resulting in neural compression, also requiring a return to the operating room. Here, where we have placement of a femoral ring allograft at the L5-S1 segment and inadvertent shearing off of a section of the posterior inferior end plate of L5 and displacement into the region of the canal and the neuroforamen, resulting in return to the operating room. Here is not an uncommon case where the patient has symptomatology following surgery, and when we do imaging, we see a large postoperative hematoma, which is resulting in compression of the neural elements. In the short-term period, where you may have temporary relief of symptoms with then early failure, the dreaded complication being infection. Here we have erosion of the end plates at the L3-4 level associated with loosening of the screws at L3. And of course, this is diagnostic of infection. The incidence of infection, of course, is tied to the length of surgery and the amount of instrumentation. You can also have dural tears, most of which we find in the early postoperative period where the patient has postural headache, but some that can go on to formation of a pseudo-meningocele. Moving on to midterm complications, we can have reherniation of disc material. This is my third recurrent disc herniation. Yes, that is my spine. We also look for the presence of scar tissue, and this is the reason we give contrast in the postoperative period to discern disc material, which will not enhance from enhancing scar tissue. Here we see exuberant perineural scar, which can be quite troublesome for the patient. Another complication in the midterm period where we have the empty thecal sac sign because the nerve roots are adherent to the sides of the thecal sac, and this of course is associated with arachnoiditis. Longer term failures tend to be mechanical in nature. Here we have a patient imaged both in 2007 and in 2010. In 2007 you can see some loss of disc height at the adjoining segment, which progresses significantly in 2010, requiring the patient to go for extension of their construct more proximally. Here is another drastic example where we had a multi-level segmental fusion for scoliosis correction with great stresses placed on the immediately subjacent level, resulting in marked facet joint effusion and formation of a large facet cyst, which was compressive. Another complication we can see in the late postoperative period is progressive kyphosis, known as postjunctional kyphosis. And you can see here in the image on the left, you can see where the hardware is in the lower lumbosacral spine and where the patient's head is, and this patient walks pitched forward. Another example here of progressive postjunctional kyphosis with the patient having a pitched forward appearance requiring subsequent instrumentation extending more proximally within the spine. The postoperative appearance of kyphosis can also be a frequent problem in the cervical spine, resulting in neck pain in 10 to 35% of patients undergoing laminectomy or laminoplasty. And of course, we have to remember C5 palsy, which can be seen in up to 5% of cervical cases. Another late complication is pseudarthrosis or failure of adequate fusion. Here you see poorly defined and developed fusion mass 9 to 12 months after the surgery. Here another case where we have obvious defect in the fusion mass in the coronal image on the left, an associated vacuum phenomenon at a supposedly fused disc level, which talks to mechanical instability at that level. Here another case in the lumbar spine with loosening of the screws and vacuum phenomenon at the fused level. And here a final case in the cervical spine with two-level ACDF where we see failure of incorporation of the interbody graft at the more inferior level, outlined by lucency. So there are forms of hardware complication that can occur at any time. And here we see a patient with loosening of the superior aspect of the long construct, pseudarthrosis at an intermediate level, vertebral segment with small vacuum phenomenon, as well as fracture of an inferior screw. Here a patient who underwent an anterior lumbar interbody fusion with the graft subsequently popping out ventrally, secondary to loosening of the retaining hardware. And here we have a patient with a disc replacement where the modular disc components have disengaged and the central polyethylene core and an inferior end plate have been displaced into the prevertebral soft tissues. That concludes this lecture. I want to give special thanks to Dr. Mark Bernstein from the ED section here at NYU Langone Radiology and Dr. Mohammed M. Samim, my colleague within musculoskeletal radiology, for the material that they gave me in order to be able to put this lecture together. Thank you.